Okay, the session is ready to start, and the case contains the most challenging cases in speakers' experiences. The first speaker is Dr. Yoon, who graduated from Seoul National University College of Medicine and was trained in Seoul National University Hospital, and he's now associate professor of Seoul National University Bundang Hospital. So, Dr. Yoon, please.
Thank you, Sean. Good morning, everyone. I'd like to show you two cases. Both cases are RF ablation of subphrenic hepatocellular carcinoma. Actually, my case is not so technically challenging, so I feel sorry for people who expected something exciting. But I just wanted to show you my experience. So as you know, the ablation therapy of subphrenic tumors is not always, but sometimes can be very tricky for these regions. So I'd like to show you some alternative methods to address the small subphrenic tumors. First case is a 47-year-old man. The ACC was firstly diagnosed in 2006, and first treatment was surgical section, but the multiple tumor, recurrent tumor developed, and 3 sessions of chemoembolization was not very successful. So finally, he underwent liver transplantation. But 3 years later, the patient suffered again from the biliary stricture and leakage. So he had to have PT with a tube for more than 5 months. He went through all these hardships, but this was not the end. So at this time, the small tumor was found at the top of the transplanted liver. We thought this is HCC based on its typical enhancement pattern. Contrast enhanced MR shows the similar features of this tumor, and there was no other tumor in the other part of the liver. Liver function was not so bad, but the coagulation was not good because the patient was on the warfarin therapy due to his cardiac problem. So in this situation, what's the best treatment option? First, the surgical resection was not an option because both our surgeon and this patient did not want to even touch his transplanted liver. And second is chemoembolization is also excluded because of risk of potential normal parenchymal damage. Of course, this tumor was not visible on ultrasound and was too small to be identified on non-contrast CT. So laparoscopic ablation seems to be a good option, but there must be severe adhesion caused by 2 times major surgery and recent biliary leakage. So our surgeon was very, very reluctant to do this. So we decided to do the thoracoscopic ablation in this patient. Let me show you a video of the procedure. Under general anesthesia, a small skin entry was made on the patient's chest wall, and the thoracoscope is now introduced. Here you can see this is a diaphragm, and this is partially deflated lung, and this is ultrasound probe. Typically, thoracoscopic ultrasound is very good to see the subphrenic tumors much better than compared to the percutaneous approach. But in this patient, the ultrasound probe was useless because the tumor was too close to the diaphragm. So the tumor was searched by using a surgical instrument, scrubbing the diaphragm and trying to feel the tumor. Yeah. Here you can see the tumor. So some little spot on this part of the diaphragm can suggest, microscopic diaphragm invasion. Yeah. And then the to facilitate the RF electrode access, the diaphragm, a part of the diaphragm should be a little bit compressed like this, and then RF electrode is introduced, approach the tumor. And then tumor was stabbed from its lateral side. This is a 3 centimeter electrode, so, and you can see the marker here. So approximately 2.5 centimeter of the electrode is positioned into the tumor. Then ablation was performed for 8 minutes. That's good. And after ablation, you can see the tumor. Not exactly a tumor, the part of the diaphragm covering the tumor turned dark, and we intentionally ablate some part of the diaphragm because of the possibility of the diaphragmatic invasion. And then after ablation, we applied the absorbable surgical felt and surgical glue like this to prevent the possible diaphragmatic defect, and then thoracoscopy was withdrawn, and that's it. Okay, this is 1 day after procedure. Here you can see some gas bubble and fluid, which possibly related with diaphragmatic injury, but they were cleared on 3 months CT, and on 1 month follow-up, we can see the ablation area is slightly decreased. There was no recurrent tumor. The most of all, diaphragm looks clear. Let me move on to the next case. The second case is a 70-year-old man. He has a lot of comorbidities, such as COPD, cerebral infarction, diabetes. There was a medium-sized tumor at the top of the right lobe. Because of his severe comorbidities, the surgical resection was not recommended, and the chemoembolization was done like this. But follow-up CT showed the washout of the lipioidal with recurrent or residual tumor here. The worst thing is the tumor is still grow upwardly with the possibility of the diaphragmatic invasion. So in this situation, what's the best option? Surgical resection, laparoscopic or thoracoscopic ablation were not feasible because of severe comorbidities. Repeat chemoembolization maybe seems to be useless. This tumor is also invisible on ultrasound, so we try to fluoroscopic ablation in this patient. First, hepatic angiogram was obtained. You can see here the hypervascular tumor, but the upper part of the tumor, I mean the exophytic part of the tumor is not opacified. So we try to find out some collateral tumor feeding artery, but failed. So to make this tumor visible on fluoroscopy, the small amount of lipioidal was injected using microcatheter. And then immediately after lipioidal injection, RF ablation was performed at the same session. This is just an example for fluoroscopic ablation from another patient, but the procedure is essentially the same. And now RF electrode is introduced percutaneous and advanced toward the index tumor here with a small amount of lipioidal accumulation. Fluoroscopy can provide real-time monitoring of the diaphragmatic movement up and down. So we can place this electrode exactly without avoiding the direct injury of the diaphragm. Let's get this. Yeah. When miss the target, we can very easily reposition the electrode, and we have to check it again with from the multiple projection of the fluoroscopy. And once the electrode position confirmed, you can use the cine-like the fluoroscopy view. And then ablation was performed, and the electrode is slowly later on ablating the data track. In this particular patient, we used an expandable tip with special attention to cover the upper part, I mean the non-opacified, exophyte part of the tumor. During the ablation, this expandable tip can be used like a hook, so being pulled down a little bit to separate the tumor from the diaphragm. And after ablation, the compression hepatic angiogram was obtained to exclude arterial bleeding. Here you can see the tumor site turned avascular, surrounded by reactive hypovolemia. This is 1 month, and this is a 12 months biopsy. You can see the ablation area slightly decreased, and especially the exophyte part of the tumor has shrunken. And most of all, diaphragm looks clear. Okay. That's it. Thank you.
Good morning, everyone. Thank you, Chairman, for introducing me. I would like to show you our no tumor touch RFA using bipolar electrodes for ACC. RFA runs the risk of causing extrahepatic seeding and/or intrahepatic dissemination. In particular, it has been reported that large tumor, poorly differentiation, high tumor marker level, subcapsular location, and the location in the vicinity of large vessel were risk factors for seeding or dissemination. To prevent this, RFA without placing electrode through ICC, so-called no tumor touch ablation, should be performed as possible. I show you our RFA technique. We used bipolar RF system, Ceylon power. Ultrasound machine is Hitachi Aroka Medical High Vision Ascendus. We used two types of probes. This is a conventional convex probe with attachment for puncture, or specialized probe for puncture. I show you a SCC protruded to gallbladder treated by no tumor touch RFA. This is a EOB MRI image. Tumor is enhanced during arterial phase. The tumor was visualized as a hyperechoic tumor with halo. I show you no tumor touch RFA in this case. Our first needle was inserted on upper side of the tumor. Second electrode was inserted on lower side of the tumor. Third electrode was inserted near the feeding artery under the real-time sonozoid US. This is the feeding artery. This is the observation immediately after RFA. This is an evaluation of treatment efficacy using enhanced sonography. This is the control mode. This is the monitor mode. The tumor was ablated completely. This is the before RFA image. This is the after RFA image. The tumor was completely ablated. Gallbladder was not damaged after RFA. Next case is a small ACC adjacent to P6 treated by no tumor touch ablation. Arrows indicate P6 vessel. Tumor is here. The ACC was unclear on B mode ultrasound. It was treated during Cooper phase of sonozoid US. I will show you the no tumor touch RFA for this case. This is a sonozoid enhanced sonography. This is a tumor enhancement. This is A6, E6. On Cooper phase, first electrode was inserted on the right side of the tumor, like this. Next, second electrode was inserted on the left side of the tumor. Third electrode was inserted on the lower side of the tumor. This is first, this is second, this is third. This is observation immediately after RFA. This is before RFA image, and this is after RFA image. Arrow shows the P6 vessel. The tumor was ablated with enough safe margin. P6 was not damaged after RFA. Next case is 8 centimeter giant SCC located in segment 8. This case was judged as unsuitable for surgical resection by surgeon. Case for RFA was performed. I show you a multipolar RFA for giant CC. This is the color Doppler imaging. This site is a residual region. This is the feeding artery. Next, sonography, enhanced sonography shows the residual region. This region. First needle is inserted near the feeding artery under sonography US. This is the feeding artery. Second electrode was inserted in parallel to the first needle. A third needle inserted at the marginal site of the tumor. This is the observation immediately after RFA. This is the evaluation CT after 9 times RFAs for the marginal site of the tumor in 3 sessions. We obtain enough safe margin. By no tumor touch RFA using multipolar electrodes, even ICC protruded to gallbladder could be safely treated. Even ICC adjacent large vessel could be safely treated. Enough safe margin over giant CC could be obtained by repeat non-tumor touch RFA for the marginal site of the tumor. Thank you for your attention.
Because time's limit, I should be hurry up. I do not have the video show, but I also present a case with advanced CC with portal-vein thrombosis. But I not only use radio frequency, also plus the artery infusion chemotherapy. This case is the 59 patient and years old patient, hepatitis C cirrhosis.